गुड मॉर्निंग मिस्टर ओनी, ऑडिबल है वहां पे? अवतार जी ऑडिबल है? डॉक्टर वनीत, you can tell Monica to try now. Yeah. Monica ji, please try to share your screen and the video.
Yes, sir, I'll do that. I'm sharing now. Is it visible?
Yeah, it is.
On the bank.
Yes.
So this is a video.
I want to thank Dr. Jairaj Pandyan and Dr. Ashish Varghese for giving me this opportunity and the whole team who will be presenting with me today. And we can enjoy this presentation and learn more about Duchenne's muscular dystrophy and also how...
That looks good. We can stop. Yeah.
Okay.
Yeah.
So I'll stop sharing at this point.
Yeah.
Okay.
Thank you. Thank you.
I thought the sound will be better in this. Kanam. The principal, the director.
Good morning, everybody. Welcome to the platforms. We have the neurology department taking the platforms today. Dr. Vinay will be the main presenter, and he has invited a group of people who are dealing with patients muscular dystrophy. Vinay is our own graduate, postgraduate, and he's done this subspecialization here only. I remember him teaching as a grade student. He was one of the smart, students who used to ask me difficult questions, and I had to go back, read, and come back and answer. And we are fortunate that he's joined the department as the faculty, and will be looking forward to your lecture. I request our director, Dr. William, to just give an introduction.
Good morning. Thank you. CMC is always at the forefront of taking care of diseases which are not common, in terms of treating as well as creating awareness, educating others. Today's topic, Duchenne muscular dystrophy, is one of them, which requires multidisciplinary approach. And if you ask me, awareness among pediatricians and other clinicians, all those who are dealing with children, they are not much aware of this disorder. I'm glad in our hospital we can provide multidisciplinary care. And as you know, this disorder needs multidisciplinary approach. We have cardiologists, endocrinologists, and all other departments. And Dr. Vinay Jason is our own MBBS, MD, and DM graduate from our institution. So it gives me immense pleasure when he is taking the lead and introducing today's topic. Thank you.
I request that Dr. Jairaj have principal of Medical College.
Good morning. So we have been having a series of invited lectures, from genomics to non-communicable diseases like chronic kidney disease. And today, every year we go through grand rounds where each department they come and present what important services that they are offering to the patients and also some new research. So today from the Department of Neurology, Dr. Vinay Jason, he's associate professor in the Department of Neurology. And he's for me as a teacher, he was my first year neurology student. And after he graduated, we were exploring which area he could focus, and neuromuscular diseases is one area as a subspecialty. It's just coming up in the country. And neuromuscular diseases, mainly the diseases of muscles and the peripheral nerves, roots, brachial plexus, and anterior muscle disease. So in one area, the muscle disease is Duchenne muscular dystrophy. It's one of the common muscular dystrophies, and particularly it starts at childhood. And it is not just a neurologist or a pediatrician who manages these patients, but there have been a lot of advances in the management of Duchenne muscular dystrophy. It is a multidisciplinary approach, and there is the option for gene therapy, and so all the advances, the entire group will talk to us and we'll do it.
This opportunity and the whole team who will be presenting with me today. And we can enjoy this presentation and learn more about Duchenne's muscular dystrophy and also how multidisciplinary care works to take care of these children. So multidisciplinary care for Duchenne's muscular dystrophy is the standard of care in the world for children who suffer with this devastating disease. And the story for us began 5 years ago when this child came to us in the clinic, our neuromuscular clinic. And he was brought to us by his mother, who had noticed that the boy was not able to walk as fast as his peers, and that he was getting, slowed down, and he wouldn't carry his bag. They initially thought that he was just being a difficult child. But then over a period of time, they noticed that he was having difficulty in getting up from sitting position, and he was not keeping up with his peers. And it was actually the principal of the school who then referred the child for evaluation. And when he came to us, we noticed that he was having a lot of difficulty in getting up from the sitting position. And not only that, he was actually not able to climb up stairs, which was causing a lot of difficulty because his parents, they live on the third floor and they were living in a rental apartment at that time. However, when they came, we noticed that he had, his calves were enlarged, and he had all the features that were suggestive of him having a primary muscle disease. This is this boy now. We just recently went to him at his home, and then we saw how he is doing. And you can see that, he has difficulty even getting up from the bed, and he cannot even get up from the lying down position. He needs to be pulled up onto his wheelchair and wheeled in and out of a room. So it's a devastating disease, which is a progressive disease, and something needs to be done for these children. So what we decided to do was that we will look into this disease and see what is best for them in our circumstances, in our situation. So what is Duchenne's muscular dystrophy? Duchenne's muscular dystrophy is the most common muscular dystrophy that we come across. And it is inherited as an X-linked recessive disease, which means that male children are affected as compared to the women and the females because they tend to be carriers. And the disease is because of a protein deficiency. This particular gene, it codes for the dystrophin protein, which you can see on the screen. The screen shows the sarcolemma, which is the myocyte membrane. And on that, you have these anchoring proteins which support each other. And dystrophin is a key protein in that. And this particular disease has a deficiency of dystrophin, which makes the sarcolemma weak. And every time the muscle contracts, causes a breakdown of that muscle, leading to damage, inflammation. And over a period of time, as the muscles start to get damaged, there is fibrosis, which prevents the muscle from regenerating. And in the net, the patient becomes weaker and weaker, affecting his muscles, which are his skeletal muscles in the hands, feet, and other parts of the body, but also his cardiac muscles. So the disease actually begins in utero. If you would check a child with Duchenne who's just born and check his CPK levels, it will be very high at birth. And as a child grows, the family would notice that the child is having difficulty in walking. And like this child, they may come and present to us. Sadly, these children become non-ambulatory, which means they're not able to walk by the age of 9. And they usually die by the age of 19 years on average. These children have 5 stages of the disease. First is the stage when we diagnose them. Second is what we call as the ambulatory and the non-ambulatory stages. So both have early stages and late stages. And what you can see here very clearly is that the loss of ability is quite predictable over the years. And you can see that these children, when they come, they have difficulty in to jump, hop, and run early in their life. And then later on, they have difficulty, like you can see this child, it's called the Gower sign. They have difficulty in climbing up, and then how they use their hands to climb onto themselves. And they have difficulty later on, even standing from the floor, following which even the difficulty is in going to a sitting position from a lying down position. And over a period of time, they lose the ability to walk and also to even stand in one place. Along with the gait difficulty, they also have problems with the upper limbs, but the distal function of the hand remain till the very end, which gives us a target which we can use to give these children function even to the very end. How do we diagnose a child with Duchenne's muscular dystrophy? Well, it is the clinical phenotype and also the presence of a family history, in which if you would ask the family history, that the male members across generations may be affected in the family. Of course, it will be from the mother's side if it is genetically inherited, or there are cases in which it may be sporadic. So just because a child has Duchenne's does not mean that the mother is carrying the carrier gene. She needs to be tested before we blame the mother as the cause for the child's disease. Also, the other thing is we would do a muscle enzyme testing, which is creatine phosphokinase, and CPK levels are usually in the thousands for these children. Once you have the clinical phenotype, family history, and CPK is elevated, the diagnosis is not very difficult, but we would subject them to electrophysiology to rule out any other problems, especially spinal muscular atrophy is a disease that we should look out for, which has different treatment and prognosis. But very often in clinics which we see patients, even electrophysiology may not be required. Having done these things, now we are quite clear that the child may have Duchenne's, and we send them for genetic testing with MLPA. So genetic testing that is done can be sent to various laboratories, commercial laboratories are there, and the genetic report would come with exon deletion or duplication in almost 85% of the cases. It looks like you can see in the upper chart there that there is a missing exon, and that is what they would report it as exon 44 that is missing in this 79 exon gene at XP21. So once we have this, we know for sure that the child has Duchenne's. But in 15% of cases, this may not pick up Duchenne's, and we might send the patient for next generation sequencing for single gene mutation. And if that also comes negative, then we can do a muscle biopsy. Previously, muscle biopsy used to be the main line of treatment, of diagnosis. But now muscle biopsy comes lower down in the order of investigations. And it is used only if genetic testing is negative in a classically suspected case. So here you can see the normal muscle and also a Duchenne's muscle in the bottom screen, in the bottom half, with a lot of fibrosis around the muscle. And you have the MGT screen and then the IF immunofluorescence markers for dystrophin and laminin, which are basically deficient in a child with Duchenne's muscular dystrophy. Has anything really changed over the years for managing these children? Why are we now interested in taking care of these children? And what difference can we make in the life of these children? Well, there has been a lot of work that has happened over the years. And the main differences that has happened is the use of corticosteroids. So corticosteroids have been studied in the late 90s, even before that, but majorly after that. And we have seen that corticosteroids really help children improve their quality of life. And it has changed many things, which we will discuss further on. My colleague will be discussing with you. The other use has been the use of home nocturnal ventilation with BiPAP. This has helped them prolong their life by almost 10 years. That is a very significant contribution. And now that they live longer, so other complications which previously were not looked at carefully, like cardiomyopathy, are also potential targets for treatment. So the surveillance and treatment of cardiomyopathy has assumed a very critical role. The other thing that we can do for these children is spinal surgery for scoliosis, because they would develop scoliosis and then that would affect the respiratory function. And in these children now with scoliosis care, which we can provide here in CMC, their respiratory function can be preserved. And the last thing, which is more recent, is the advent of gene therapy for these children. So this chart it just depicts the progress that has been made over the years from 1960s till our contemporary treatment with steroids and improved cardiac management. That their diagnosis has become earlier, And also we've been able to push their ambulatory stage by a few years, but more importantly, even their requirement of ventilation and even death has been pushed by several years, if not a decade. So the mainstay, like I mentioned, was steroids. Now, steroids is given usually at the dose of 0.75 mg per kg. And like you and I, we all know that steroids is not an easy drug and has several complications. So we need to manage these children in a multidisciplinary care management, where now, apart from respiratory specialists and cardiac specialists, we need endocrinologists also to help us. These children need nutritional support, and because steroids comes with its whole burden of side effects. We know that they can develop life-threatening infections for which we need support from the pediatricians. They have abnormal behavior, they can develop fractures. So orthopedicians well versed in the care of these children need to be prepared to take care of them. They have weight gain, so nutritional assessment is also very important for these children. Also, they have height restriction for which the growth of these children needs to be managed in a particular way so that we know how and when to intervene. So the care of these children can no longer be done by individual clinicians. And it is very important that we have a multidisciplinary team looking at these children and supporting them alongside their growth. And as the years go along, especially even the non-ambulatory phase and when they become critically ill, we need to have people surrounding the family who would understand the needs of this particular child, this particular family. So I would now like to hand over the rest of the presentation to my colleagues who will be giving you an understanding on what they do in the care of these children. Thank you.
I'm Dr. Santosh Matangana. I'm going to today talk about rehabilitation management of Duchenne muscular dystrophy. Duchenne muscular dystrophy, we have seen that with the rehabilitation, over the years, we are able to actually prolong the ambulation of these patients because these children become bed-bound or wheelchair-bound and unable to walk. But with the intervention, we are able to see that their ambulation could be prolonged and more number of years they could walk on their own or with the supportive structure. We also saw that we could decrease the contractures and deformity of these patients. This deformity can be prevented in the form of scoliosis as they might develop. That can also be prolonged through rehabilitation. We have a vibrant team of rehabilitation members in CMC Ludhiana. We have physical therapists, we have occupational therapists, speech therapists, and orthotic and prosthetic people. We also have nurses who are rehabilitation nurses who are supporting our department. We do the assessment of these patients around 4 to 6 weeks to 4 to 6 months. Occasionally, we might change it because based on the need, sometimes clinical scenario might change and requirements might be there. So we will do the assessments quite early. What do we do in the assessments is that we check actually range of motion of these patients, joints, posture of these patients, strength of these muscles, function of these muscles, stretchability of these muscles, and also quality of life of these patients. These assessments can be done with the help of some scales called as North Star Ambulatory Assessment, 6-minute walk test, functional and independent measure scales. There is a growing need of this assessment of children, of infants or young children, because with the assessment, then we are able to come to a diagnosis, and then early intervention can be done for these children. For that, we use something called as Bailey-III scale, Griffith Mental Development Scale, etc. Some of the children who are non-ambulatory adult patients, we use something called as Brooks Upper Extremity Scale for their measurement of upper limb strength. Here, I wanted to emphasize two aspects. That is, first is to assess the amount of challenges that we have in these children and what are the interventions or treatment modalities that are available and that we are providing in CMC. These interventions have to be tailored for individual needs. They have to be given at the different stages of the disease, and we should see the response for the therapy of these interventions. Whether these children can tolerate enough exercises or not. But one important thing is that these interventions have to be provided throughout their lifespan. What do we do in these interventions? First thing is prevention is better than cure. So we try to prevent contractures and deformity of these patients. We provide stretching of the different types of muscles and joints of around 4 to 6 days in a week, which includes stretching of ankles, knees, and hips, etc. And for patients later in life, maybe upper limbs are involved, then we use stretching of the wrists, hands, and neck in the later stages. We have an orthotic department which provides us with different types of splints which are required and have to be judiciously used in these patients. Those are called as ankle foot orthosis, knee ankle foot orthosis, lock knee joints, etc. Some of the children might need wrist splints or hand splints. And some children who are using motorized wheelchairs or manual wheelchairs, their seatings should be looked after. So sometimes we customize these seatings for these children. Some of the children might require serial casting of the tight structures, tight muscles and tendons. Exercises that we give are regular exercises of submaximal aerobic activities have to be given. And these exercises we give on a daily basis on an OPD. It should be available in an OPD, or sometimes when they go to school, they are supposed to be provided in the school as well. And when they get admitted for some various reasons, we do inpatient physiotherapy as well for these patients. What has to be kept in mind is avoid high resistance exercises, or what we say is strengthening exercise should be avoided. So, and during these exercises, respect should be given for rest for patients. So while doing exercises, we should give adequate rest for these children. And risk of muscle damage can also be there sometimes, even though functionally they seem to be okay. So one of the few things that we advise is swimming and cycling for these children are recommended. Few of the things that we need to look into is falls and fractures. For prevention of falls, we need to give supporting structures for these children, like holding a cane or a elbow crutch or braces or long leg casts in the knees to be preventing from flexion deformity. So we can avoid falls, but if there are fractures, we have to make sure that they quickly refer to the orthopedician, and as quickly as possible we can bring them back for mobilization. We also use assistive technology and adaptive equipment. In adaptive equipment, what we use is elevated lap trays, adaptive straws, home renovations, including bathroom renovations and hoists for lifting the patients. And we use stairs or ramps and all this. So, and adaptive includes using the Bluetooth or voice activated home appliances can be used when patients cannot use these gadgets on their own. We can use voice activated equipment in the house. Last but not the least, but we can talk about pain prevention and management. Some of our patients complain of pain because of the contractures and tightness in these muscles, which will cause severe pain. For that, we do something called physical therapy modalities we use, and we also give pharmacological intervention. Some patients given injections into this painful joints and painful point. So take home message is that we should do early diagnosis of these children with Duchenne muscular dystrophy, which helps them in giving a proper treatment, and then the outcome will be better.
Good morning, everybody. The hereditary neuromuscular diseases are commonly cause cardiac manifestations. And the cardiac manifestations have varied phenotypes. As you can see here, the diseases can cause dilated hypokinetic ventricles. It can cause hypertrophic ventricles. It can cause restrictive ventricular disease, or can present with cardiomyopathy, common rhythm defects, and conduction problems. The Duchenne's muscular dystrophy primarily produces dilated cardiomyopathy, and in the later part can also cause conduction disturbances as well as arrhythmias. Historically, the most common cause of death has been respiratory failure. However, with improved respiratory support, an increasing important source of morbidity and mortality is cardiomyopathy, leading to heart failure and arrhythmias. It is very important for us to see the cardiac phenotypes and the genotype correlation. Cardiodystrophinopathies can present with a number of phenotypes with the same genotypic pattern. And they can present with a Duchenne's type of muscular dystrophy, which presents early with severe cardiac involvement, or can present late with Becker's dystrophy. Sometimes the Duchenne's genetic pattern can also present with a dilated cardiomyopathy without much of neuromuscular involvement, or sometimes can also have just hypercikemia without a cardiac or muscular involvement. But these are the patients who are at a higher risk of developing cardiac complications at a later age. A cardiologist is involved in the management of these patients in a number of ways. These patients can have cardiac manifestations in the form of a dilated cardiomyopathy, conduction diseases, atrial and ventricular arrhythmias, or episodes of sudden cardiac death. A number of electrocardiographic and electrophysiological findings may be present, and a goal-directed treatment is recommended for them, that is for the medical management, a pacing, or an ICD implantation. The cardiomyopathy which occurs in patients with Duchenne's muscular dystrophy differs with the other causes of pediatric dilated cardiomyopathy. These are that only 30% of the young boys with Duchenne's muscular dystrophy have cardiac symptoms at diagnosis, far fewer than the other dilated cardiomyopathies. This is because most of the symptoms are attributed to the neuromuscular problem rather than the cardiac. There is less left ventricular enlargement as compared to the other cardiomyopathies, and it's often less treated at the time of diagnosis, makes it more important for a cardiologist to be involved early so that early treatment can be started. There is higher mortality for Duchenne's cardiomyopathy than for other dilated cardiomyopathies. You can see an echocardiogram of a child being performed here, and you can also see that the patient has dilated left ventricular chamber, and a color Doppler shows mitral regurgitation. How do we approach these patients with Duchenne's muscular dystrophy? So all patients with Duchenne's or Becker's dystrophy should have an initial cardiac evaluation with clinical examination, ECG, and imaging, primarily echocardiography, at the time of diagnosis. Every 2 years, cardiac evaluation by examination, ECG, and a non-invasive imaging is reasonable in asymptomatic patients who are less than 10 years of age, which can be increased to annual evaluation as they achieve 10 years of age or later. Asymptomatic patients with LV dilatation or dysfunction or arrhythmias, that is supraventricular tachycardia or ventricular ectopics, should be evaluated at least annually. Symptomatic patients should be re-evaluated more frequently than annually, with testing and frequent determination determined by the provider and clinical status of the patient. It is important that the female DMD carriers should undergo cardiac evaluation by examination, ECG, and non-invasive imaging in the second to third decade of life, with follow-up evaluation every 3 to 5 years thereafter, because they may be totally asymptomatic and may have normal cardiac findings to begin with, but they are at a high risk of developing dilated cardiomyopathy later on. What are the basic investigations which are required? Echocardiography, both two-dimensional, color Doppler, is the key to the investigative process. You can again see here one child having an echocardiographic procedure and the echo showing dilated left ventricle. In patients where the echo windows are not very good, or where you want to pick up a cardiac fibrosis early in the disease, advanced tissue imaging like CMR with contrast, that is computerized magnetic resonance with contrast, should be done. Ambulatory electrocardiographic monitoring is another very important investigation which is required to pick up any arrhythmic event in these children. Arrhythmic monitoring at least annually is reasonable for all patients with Duchenne's or Becker's muscular dystrophy with ejection fraction less than 35% or age more than 70 years, so that a decision about implanting an ICD can be made. What are the medical therapies which we can give to these patients? A number of medications have been used in these patients, and the cornerstone of therapy is ACE inhibitors or angiotensin receptor blockers. The use of ACE inhibitors or ARBs in the setting of a reduced left ventricular ejection fraction is recommended for all DMDs as it is for any other cause of heart failure with systolic dysfunction. The use of an ACE inhibitor or ARB before the onset of reduced EF in boys with age more than 10 years may also be considered. Beta-adrenergic blockers used in the setting of DMD with reduced EF is recommended as for other heart failure causes. Mineralocorticoid antagonists, it is reasonable to consider the use of aldosterone antagonists in DMD with systolic dysfunction. Now, use of aldosterone antagonists in these patients with preserved left ventricular systolic function, particularly in those who have evidence of myocardial fibrosis on CMR, may also be considered. Glucocorticoids, the use of glucocorticoids to slow the progression of neuromuscular disease is described, and the same holds true for cardiac disease also in these patients. Diuretics to be used as required to maintain a euvolemic state. Other advanced therapies have a very important role, like implantable cardioverter defibrillator and resynchronization therapy. It is reasonable to consider ICD replacement in selected patients, particularly in which arrhythmias may be a predominant feature, after thoughtful discussion and decision-making, which could be individualized and based on overall medical status and options for management. They are useful, but need to have a very detailed discussion with the family because these devices can have their side effects or problems also. Patients who do well on these managements and progress in life also may require end-stage heart failure therapies like mechanical circulatory support, and patients, especially with Becker's type of muscular dystrophy, can be candidates for cardiac transplantation. Home parenteral inotropic therapy is also of use in some of these patients. All these things are done basically to provide the best possible state-of-the-art care to these patients who are very unfortunate to have this disease.
Good morning. I am Dr. Neeru. I am working in pulmonary medicine in CMC. Today, I'll be discussing the respiratory management in Duchenne's muscle dystrophy. Respiratory muscle weakness due to the neuromuscular disease can lead to acute and chronic ventilatory failure, as well as recurrent episodes of aspiration, pneumonia, mucus plugging, and muscle fatigue. So intervention should be started as early as possible, preferably at the time of diagnosis, to prevent lengthy hospital stay, to decrease the episodes of dyspnea, and to improve the quality of the life of the patients. So surveillance should be started according to the stage. That is, it depends upon the ambulatory stage, early non-ambulatory stage, and late non-ambulatory stage. So during the ambulatory stage, the spirometry is performed yearly. The parameter which we follow closely is FVC, that is forced vital capacity. So usually the forced vital capacity increases with growth until the patient becomes non-ambulatory. Once the patient becomes non-ambulatory, FVC reaches a peak followed by a plateau, and then it deteriorates over time. So deteriorating FVC can occur even in the absence of dyspnea, and it may go unnoticed unless the PFT is being performed regularly. Then we can do a sleep study for patients who are not compliant with spirometry, or if patient shows any signs and symptoms of obstructive sleep apnea or sleep disordered breathing, or has weight gain. Patients should be given immunization with inactivated influenza vaccine yearly and with pneumococcal vaccine once in 5 years. A complete respiratory examination should be done when the patient comes to the hospital, and if patient has any respiratory complaint, then we can order an X-ray or the investigations according to the patient's complaints. During the early non-ambulatory phase, the PFT should be done twice, and the parameters monitored are forced vital capacity, maximum inspiratory pressure, peak cough flow, saturation, and carbon dioxide retention. Then, as the vital capacity decreases, patient develops stiff and non-compliant chest walls and lung volume restriction. To preserve lung compliance, lung volume recruitment is indicated when FVC is less than 60% predicted. So this is done with the help of manual ventilation, bag or insufflation, exsufflation devices once or twice daily. During the non-ambulatory phase, patient develop weak cough reflexes, so which increases the chance of atelectasis and pneumonia, ventilation perfusion mismatch, and respiratory infections, speeding up their respiratory failure. So we should teach the patient secretion mobilization techniques, that is either manually or with the help of high frequency chest wall oscillation devices. Then assisted cough techniques can be performed manually, that is by giving abdominal thrust, or with the help of mechanical insufflation exsufflation devices. And we have to increase the frequency of the assisted cough techniques if the pulse oximeter is showing saturation less than 95%. So during the late stage, these patients may need nocturnal ventilation and assisted day ventilation, that is with the help of BiPAP and home ventilators to prolong their survival. Tracheostomy is indicated if all the cough reflexes fail and if NIV fails. Lastly, counseling is very important. We have to counsel the parents and the caregivers to perform the maneuvers, the use of ventilation devices, and to look for danger signs so as to bring the child to the hospital as soon as possible. Here in CMC, we are performing spirometry, sleep studies. We can do a full respiratory examination, and we can teach the family the use of non-invasive ventilation and devices in order to improve the quality of the life of the patient and to prolong their survival. Thank you.
Good morning. I will be discussing the GI evaluation of patients with muscular dystrophies. The oropharyngeal involvement can occur in up to 1/3 of patients with muscular dystrophies, and these patients can present with solid food dysphagia. In contrast to most central neurological disorders, dysphagia is more prominent to solids in these patients, while in central neurological disorders, liquid food dysphagia is more common. So these patients can present with a myriad of symptoms, including discomfort during swallowing, coughing while swallowing, loss of appetite, increased meal duration, chest infections, choking episodes, and unintentional weight loss. Any weight loss more than 10% in a year is considered to be clinically significant, and this needs to be further evaluated, as I will discuss subsequently. Dysphagia can be classified based on 3 stages. The first stage is the accumulation of residues within the supraglottic area in the piriform sinuses. Once the food particles, they enter into the glottis. So once the food enters into the glottis, this is known as penetration. At this stage, the cough mechanisms may get triggered and this food can be expelled out. However, if the cough mechanisms are weak or they are overwhelmed, then the food may enter down into the subglottic area, and this is known as aspiration. Clinically, it is important to differentiate between these 2 stages. The differentiation of aspiration from penetration or accumulation of residues can best be performed with the help of a video fluoroscopic swallow study, while the differentiation of penetration from accumulation of residues is performed with the help of a fiber-optic endoscopic evaluation, which can be performed either by a gastroenterologist or an ENT surgeon. While evaluating dysphagia in these patients, it is also important to look for any evidence gastroesophageal reflux or arterial desaturation, because these are the close mimics of dysphagia, and they can also worsen the dysphagia if it is already present. The mechanism of dysphagia in arterial desaturation is through the fatigue of oropharyngeal muscles, which worsens the dysphagia, and this can also lead on to significant aspiration as well. Now, this is the algorithm to show how to evaluate the patients from the GI perspective. A 6-monthly visit to a gastroenterologist is desirable, and at every visit, one has to look for any evidence of dysphagia, loss of weight, or lung aspiration. The closed mimics of dysphagia, the reflux, as well as the arterial desaturation needs to be seen and evaluated and treated. If after treating these mimics, still there is dysphagia persisting, one has to look for any evidence of penetration, residues, or aspiration. In the absence of aspiration, PEG tube feeding has to be instituted. Also, the tracheostomy has to be placed, especially in those cases if there is insufficient tracheal clearance. If there is dysphagia, there is penetration or residues without lung aspiration, one has to remove all the solid food, including the mashed and the minced food. Only pureed food along with liquids has to be given to these patients. Besides, if there is dysphagia, there's no penetration or residues, and there's no loss of weight, one has to implement the mealtime strategies. These include giving frequent small volume meals, along with changing the consistency of the meals. From the solid food, one can convert the food into minced or mashed food, and also liberal liquids can be given. So if there is dysphagia without penetration or residues, along with loss of weight, a trial of high calories can be implemented. If this is not successful, then one has to go for PEG feeding. So ultimately, most patients of dysphagia in the setting of muscular dystrophies will require PEG feeding. So this is the cartoon showing the concept of percutaneous endoscopy gastrostomy tube placement. I will not go into the details of the procedure as this would be beyond the scope of the present forum. Conceptually speaking, a tube is placed into the abdomen across the musculature into the gastric lumen. And this tube is used for feeding with the help of a feeding string, and routine tube care is implemented. So the indications of putting the PEG tube in this patient is if there is aspiration, and second indication is if there's dysphagia without penetration or residues, and along with there is a significant weight loss, and this weight loss is not responding to mealtime strategies as well as a trial of high calorie diet. So if there is a weight loss, even after giving full trial with the high calorie diet, one has to go for PEG tube placement. Thank you.
So I think this is the part where we talk about endocrine evaluation of the children with Duchenne's and other inherited myopathies. I think the cornerstone when we see a child with any kind of muscular dystrophy or in fact any kind of disease is growth assessment. And I think it is very simple by using standard growth charts. And I think every child, this doesn't need to be done in the endocrine department. This can be done in the neurology department itself, where every child has a growth chart in his file, and the plotting of the growth is every 3 months or as often as the child visits the clinic. And I think what is important is that if there is any suggestion that there is a downward crossing of the height percentile or height velocity is not more than, for normal children, we say not more than 4 centimeters per year, but for Duchenne's maybe even lesser. And if the height is falling below the 3rd percentile, we would do further assessment, including, standard assessments, thyroid, celiac panel, look for other metabolic profile, bone. And that's, I think, a vital part. So I think at least once a year growth should be assessed by an endocrinologist, but every visit, as long as the child is ambulant, he should have height monitoring them. Pubertal assessments will start from the age of 9. And I think they're standard genital pubertal assessments, Tanner staging, and for boys at the love volumes. And if there is no sign of puberty by the age of 14, further assessments can be done, including hormonal. Then appropriate drugs will be given to induce puberty. I think the 4th or the 3rd part of endocrine assessment is assessing bone health. And we know that there are 2 reasons for children with muscular dystrophy, poor bone health. One of them being that the mechanoreceptors in the bones are not going to get activated. So they are not going to lead to activation of bone formation. So that's going to lead weak. Plus, the standard of care for these children are the use of very significant doses of steroid. That also would impair health. So bone health needs to be looked at, and this needs to be looked more carefully in patients who are being prescribed steroids, and this needs to be done at least once every 6 months. Each time it does not need to be a DEXA scan or a BMD assessment, but bone assessments in terms of eating. The recommended daily allowance, is he getting enough vitamin D? If not, measure it and provide them adequate supplements so that these two RDAs are met. And finally, I think the most important, one of the reasons why these children can succumb is steroid. And that really happens when the child is on chronic steroid and he becomes very unwell. He starts vomiting, he has diarrhea, and the physician or the caregiver has not trained in recognizing that these children were taking such high doses of steroids, not got the steroid for the last 12 hours, 18 hours, and they are very developed acute steroid insufficiency and even succumb to it. So steroid education, the patient and the caregiver is important. I think very important that we teach the caregivers how to give a dose of hydrocortisone if required intramuscularly in children who are vomiting, who are not able to keep down their oats. This is the last part of the endocrine assessment. Thank you.
Good morning, everybody. I am Dr. Nidhi Agarwal, clinical psychologist at CMCL-Duchenne. Today, I am going to talk about psychological aspects of DMD, psychological assessment and interventions, brief screening of emotional status and quality of life at every clinic visit or on an annual basis at a minimum would be required. Emotional adjustment screening can be informal and does not require a comprehensive assessment. Use of short standardized rating scales might be useful. The longitudinal assessment gives the psychologist the opportunity to build a professional relationship with the patient and the family, which is an asset in the patient's mental health care needs intensify over time. Neuropsychological assessment recommendations. Comprehensive development assessment is required for kids below age. Neuropsychological assessment in kids above 5 years would be required. Comprehensive development would be characterized by cognitive, emotional, social, and academic skills, development of a plan to address their areas of functioning, diagnosis of comorbid neurodevelopmental conditions, for example, autistic spectrum disorder, learning disability, ADHD, and so on. The evaluation should be near the time of diagnosis or before entering the formal school and every 2 to 3 years to monitor the developmental progress or when there are concerns about the changes in the developmental trajectory. Patients with DMD can have low intelligence or significant areas of difficulty in learning, but it's not all and none case. Several of them have average intelligence or above average intelligence also. Assessment of speech and language. Younger children suspected with delay in speech or language development should be regularly assessed for the same. Older patients who present with loss or impaired functioning of communication ability should also be assessed for the same and then enrolled for the therapy. The psychological management through psychotherapy, parental management training for externalizing behaviors, for example, non-compliance, disruptive behavior, parent-child conflict, individual psychotherapy for internalizing behaviors, for example, low self-esteem, depression, anxiety, OCD, adjustment disorder, difficulty in coping, helplessness, and many other areas. Group therapy for social skill deficits, family therapy for adjustment and coping difficulties and parent-child conflict resolution, applied behavior analysis for specific behavior related to autism and other comorbidities. Mostly it is seen that they are symptom-based and the management has to be planned for individual child individually.
Thank you everyone for that wonderful presentation. I think this makes it very clear why multidisciplinary care is so essential, and it is not possible for us to care for children with such complex diseases alone. And coming together makes all the difference in these children's lives. The child remains at the center of our focus, surrounded by his own family and connecting with the clinical facility with the clinical care coordination. And all of this is possible only because of the willingness of the clinicians to come together in this form as a multidisciplinary team. And I want to really appreciate and thank all the clinicians who have come together and agreed to be a part of this. And I'm sure there are many more who are not listed here who would be interested in joining to take care of these children and many other children who suffer from diseases that don't have a simple cure. And this is possible in our institution because that's what we stand for. This is a video of a child. I believe that every child has a right to happiness, a right to a family who cares, a right to be able to study, go to school, to be able to do everything that any other child would do, to have friends come home, if not possible for the child to go to their houses. And this is what we seek to do in our department, in our clinic, and also in the future to be able to set up a center of excellence in neuromuscular diseases, which would look at several aspects of caring for people with neuromuscular disorders. In the end, I would like to just end with a quote, which is from scripture, which says that what you do for the least of my brothers, you do unto me. And I hope we will be able to do something, even if it is a small step in that direction, for the care of these children. And I want
clinicians who are involved in this, but we couldn't get the contribution right now, but we are working towards coming, writing a document and coming together so that these children are taken care of well. I also want to just thank Monica and Jeff who helped me put this thing together. If there are any questions, I'd like to take questions.
We have Dr. Raju Abraham, who is a visiting neurologist. Sir, how would you see this kind of patients in periphery and how would you manage?
We've seen occasionally muscular dystrophy in hospital. One case that I can remember, we had problems in school. We had to advise the school to have his class at ground level. Otherwise, he had to be carried to the likes of stairs. And so we were visiting him at home and so on. So it is a problem, but I mean, we don't see so much, but we've seen a few cases. But it's interesting that you've doubled their life expectancy from 90 to 30. So you've doubled their life expectancy, which is amazing. With all the facilities that you have, it's going to be. I didn't know there were so many things that they suffered from gastroenterology and respiratory disease. So it's very interesting. Thank you.
There is one question in the chat. What is the role of counseling of parents and mothers with child having deficiencies?
It's a very significant role. I think counseling them has played a very important role in preventing this disease from future generations having it. At the same time, when we counsel them, it is very important in our social structure to be wise in how we convey the diagnosis to them. Because if the family comes to know So if the mother is responsible for this disease, then the way society would look at her is also
Doctor,
Pennington cardiology. And it's very good that we don't work in a multidisciplinary where everybody will be involved in everything. So that we don't miss out rather than too early. But those monitoring and all, we are doing it and it should be done regularly so that it's there is a side effect we can handle. And also for ophthalmological checkup, we get that only as well. So I just want to say this endorsements, they have more behavioral problems. And so we have to screen them because they actually are on media most of the time and they tend to pick up by their behavior. So that bit also has to be taken. And immunization is a very important aspect because we want to prevent flu-like illnesses and superactive infection, like pneumococcal infection is common on the. So we give them all the right vaccines before we start here. So that, because immunosuppression because of fever will convert us to right vaccines, but inactivated vaccines can be given. Annual influenza vaccine, as Dr. Lee said, and pneumococcal vaccine, conjugate followed by polycystic vaccine. It can be repeated every 5 years. And early pick-up of infections is very important, so that because here to infection and treatment is very. With this word, actually, I'm very happy that we are part of this team and we will be help children. But other advanced therapies also. So I would like to know whether we are using or in India it's not used balance in the Dystrophy. And even the has to build up strength from us. Is there any role or
So gene therapy is the new thing that is coming up for children with Duchenne muscular dystrophy. And there are several ways that they are targeting to modify the gene or upregulate gluten, or also to be able to insert the microdystrophin. Most of the therapies have looked at converting a Duchenne phenotype into a Becker's phenotype, which is a better phenotype. And it all depends also on the genetic problem, the exact genetic problem that the child has. In India, there was a trial, actually, Athilurin is a particular drug which has come to look at nonsense codon. Nonsense codon is when there's a particular mutation which puts a end stop codon. So that causes the protein not to be fully expressed. So in children, like I said, around 85% will be picked up on MFPA, then you have to do next generation sequencing. And if you find this particular nonsense codon causing the genetic defect, then Athilurin is a drug which can be given as an oral tablet, which can be given to these children. However, these are very expensive and not available to the common man. But it has shown improvement even in the walking capacity, ambulation in these children. We usually do a 6-minute walk test, so we make them walk functional assessment, and there has been improvement. They've also looked at the increase in the dystrophin present in the muscle. So that is one way of doing it. Then there are also exon skipping mechanisms, but there are particular exons, especially 344, and a few of those exons which are causing this particular defect. So then and it is an outer frame mutation. So we cause them to change it, and then there's overriding, and the whole protein is then expressed. Although it may not be a normal protein, but it is enough for the muscle not to break down as easily and as frequently. So these things are very much a part of research, and some of them are available even in the market. In Europe, it is approved. FDA has not yet approved Athilurin, but these are things that are very much.
Thank you, Vinny, for that presentation and taking all the questions and giving us details on the gene therapy. 23rd of March last year was the lockdown which was declared all over the country. And since the lockdown, two departments were actively involved in RT-PCR testing. The next Saturday, you will be having the Department of Microbiology with the Betty Cowan Research Center presenting their 1 year's work on the RT-PCR and the COVID testing that they were doing. So please do join us next week, Saturday 8 a.m. Thank you very much.